All right, so thanks, Pavel. Again, my name is Nick Radov. I'm an engineer and product manager working for UnitedHealthcare. Been dealing with clinical systems interoperability for over 20 years now and HL7 standards. Started out working for a startup 20 years ago called AXLOTL. It was a health information exchange vendor, so I got some of my old colleagues, AXLOTL colleagues from there, so welcome, guys. And today I'd like to talk to you a little bit about what we've been doing lately in the HL7 Da Vinci Project for using FHIR standards to develop value-based care use cases for interoperability between payers, insurers, and provider organizations. I've come in uniform. I've got my Da Vinci golf shirt and my HL7 FHIR socks, if you can see. So.
Show the socks.
All right, so I'll spend most of my presentation talking about an overview of the Da Vinci project and then show you just a little bit of what we've been doing internally in UnitedHealthcare to implement Da Vinci use cases. So Da Vinci is oriented around value-based care. One of the big problems in the US healthcare system today is it's still mostly a fee-for-service model. So you go and you see your doctor, she does something to you, and then submits a claim to the insurance company for those procedures. So it's there's not necessarily any incentive to cut costs or deliver better actual care to patients in that model. You're just charging for services. But there's a gradual shift underway from that fee-for-service model toward value-based care, where we try to pay providers for delivering positive outcomes for patients, for taking better care of patients, so we get those incentives properly aligned. And there's a variety of different value-based care models out there, anywhere from bundled payments for a whole course of treatment for common procedures like joint replacement or something, all the way up to like an accountable care organization model where we shift the risk almost entirely to the provider organization, just pay them like a per member, per month fee to take care of that patient and do whatever is necessary to keep them healthy and along with care quality guidelines. Unfortunately, the existing systems and standards out there today were pretty much all built around the fee-for-service model. They're not very well suited toward value-based care. So that's where Da Vinci comes in. And then we're trying to build out use cases, implementation guides, reference implementations to really support those value-based care interactions. So right now, we're still kind of on the left side of this curve here, where most provider revenue is coming from that fee-for-service model, very little from value-based care, but we're slowly moving toward the right. We all expect that this is kind of an inevitable trend, that eventually most care will happen under some sort of value-based care model. So Da Vinci is really trying to drive the standards for interactions between payers and providers. There's a number of different HL7 accelerators out there, but like Argonaut Project and Karen Alliance and a couple others, each of them have their own focus area, and Da Vinci is really looking at the payer and provider interactions. So Da Vinci is an industry-led initiative. We've got several different groups of members. We have provider organizations, including some of the local folks like Sutter Health. We've got many different payer organizations. So I work for UnitedHealthcare, one of the biggest, but we've got many of our other competitors are cooperating with us in Da Vinci. It was actually one of my boss, Sagren Moodley, that was one of the major movers to get the whole thing kicked off a couple years ago, but other key people in those payer and provider organizations have also been heavily involved. And we have quite a bit of support from vendors, major EHR vendors like Cerner and Epic and Allscripts and Athena Health and other vendors. On the payer side, we can kind of build our own systems. We have the resources to do that, but providers are typically dependent on vendors to implement these standards. So they have to be in the mix, and they've been very helpful in getting this stuff moving. So Da Vinci is oriented around what we call use cases. We try to define individual use cases for these various interactions and then build out very detailed technical implementation guides, all based on HL7 FHIR plus other standards like CDS hooks and OAuth. So this diagram here shows all the use cases that we have kind of somewhere in flight today. And it starts from the bottom, kind of least mature, going to the top, most mature. So these reddish ones here are use cases for which we already have a fairly complete implementation guide that's gone into the HL7 formal balloting process. The standards development organization, everything goes out for public ballot and everything's done in the open. Moving on down the line here, there's some others that are not quite complete yet, but are headed for ballot soon in HL7, and then others that we're still kind of doing initial analysis and discovery, so they're very much incomplete. They've got a lot of holes. But these ones, at the top here, these reddish ones, those are like really ready. I mean, you can take the implementation guides and code to them. You can use the reference implementations that are open source as a starting point for your own implementations. And I'll talk a little bit more about some of those use cases later in the presentation. So this is another view of the use cases that we have, kind of broken out by functional area rather than maturity. So for example, we have several related to coverage and burden reduction. If you talk to any doctor, any provider organization today, like one of their biggest complaints, one of the things, the previous presenter talked about physician burnout and unhappiness. Well, one of the big reasons is all the effort that they have to spend dealing with prior authorizations and getting approvals from insurers to treat their patients. So we're trying to automate a lot of that wasted, unnecessary work away through those coverage and burden reduction use cases. Or we also have another set of use cases oriented around clinical data exchange, so just moving the clinical data back and forth between payers and providers. We're talking about records of their conditions and encounters and medications and procedures that have been carried out, so all that stuff. What else on the quality side? This is another one I've dealt with, quality improvement. Data exchange for quality measures. So, insurers are measuring providers to see that they're adhering to certain standards of care. The federal government actually looks at that too. Like for Medicare plans, they want to see that the providers are taking good quality care of beneficiaries of patients. And so they have certain defined standards of care and metrics that they use to measure those.
Curious why the transparency portion is still in discovery, because my understanding is becoming a commodity now, more or less, right? The service side of transparency. Well, not at all.
You're talking about the patient cost
exactly, yeah.
Transparency? Yeah, so we had to prioritize. There's a lot of stuff that people want to work on, and these other ones just were more urgent at the time. Da Vinci's only been around for a couple years now, so we can only do so much, but cost transparency.
If I go to Quest to get my lab test, because if I get in hospital, there's a huge delta, right?
Sure.
I would assume you'll be incented that I go to Quest if there was a transparency data in front of me and just say, hey, don't go here. Go to Quest instead. Right,
and most payers do have some kind of mechanisms that they've built out already for that sort of thing. Yeah. But obviously we want to standardize that a little more and provide a common standardized experience for the providers so that it's not different for each different insurer. So let me just talk a little bit about some of the specific use cases. I don't have time to go through all of them today, but just to give you a flavor of it. So on the burden reduction side, one of the first ones we dealt with was coverage requirements discovery. Pretty simple. It allows when a provider, doctor wants to give some sort of treatment to a patient, whether that's carrying out a surgery or ordering a sleep study or giving them like a medical device, a home oxygen therapy device or something. They want to know, they want to have a standard way of asking the patient's insurance company, do I need a prior auth for that? Sometimes they waste time asking for prior auths that they don't even need one, right? And sometimes the rules are not clear about where a prior auth is needed or not. So the coverage requirements discovery, the CRD use case, gives them a standard way in their EHR that they can ask, they can send a query to the insurer, whether it's UnitedHealthcare or somebody else, and say, hey, I've got this patient in my office. I want to give her this medical device. I want to carry out this treatment. Do I need a prior auth? And it'll give you back yes or no answer, or maybe, maybe I need more information to give you a clear answer. But that, saves a lot of time right there, just something that simple. Beyond that stage, we also have what's called the document templates and rules use case, a DTR, that kind of works with CRD as the next step in the workflow. So with DTR, the provider can again query the insurer and say, for this case, what sort of documentation do I need to give you about the patient? What pieces of the patient's chart do I need to supply in order to justify that this treatment is medically necessary and covered? And you can get, this works, by the way, through CDS hooks, if you're familiar with that. So we send a query to the payer, you can respond back with a set of cards from that hook. Right. And then a newer one kind of in that same area is actual prior authorization support. So right now there's a federal regulation that all prior authorizations have to go through the X12 EDI standard. You have those 278 and 275 transactions. So what we do, and those are difficult to work with. It's just kind of a mess. Old legacy software, the interfaces are difficult. The message formats are problematic. So we're still required to use X12 somewhere in the middle because that's actually a federal requirement. But what we've done in Da Vinci prior auth support is allow you to have FHIR-based layers both on the payer and the provider side. So the provider's EHR can just talk to a nice simple FHIR API, and then same for the payer side, they can talk to a nice simple FHIR API, and all the difficult parts of dealing with X12 happen in this sort of magic box in the middle. So it shows kind of the whole overall workflow where you start with coverage requirements discovery, CRD, move on to DTR, and then finally prior auth support to actually send the prior auth request and get it back. So on the quality improvement side, big one is the data exchange for quality measures, the DEQM use case. So that allows payers and providers to exchange data for quality measures, measure care quality adherence. And so we've looked at a number of different sort of sub-use cases, individual sets of data within that. One of the big ones that we've focused on is dealing with 30-day medication reconciliation. So those of you that are clinicians probably know that best practice when a patient is discharged from a hospital, within 30 days, hopefully much less, some clinician, whether that's a physician or nurse or pharmacist, does a detailed medication reconciliation and looks at, okay, what was this patient taking before they got admitted to the hospital? What medications were they prescribed during their hospital stay? What's on their discharge instructions? There's often been, it's been a huge source of harmful medical errors. Patients getting the wrong prescription, taking the wrong thing, bad interactions, wrong dosages. So it gives you a good chance to double check that the patient has the right medication list, that they're taking the right stuff after the discharge. Helps to avoid readmissions back to the hospital. due to that type of error. So again, DEQM allows you to exchange all that data and to verify that that procedure was actually carried out. And there's other use cases we've focused on as well, like colorectal cancer screening, venous thromboembolism prophylaxis, some others. In principle, this can be used for really any quality measure, but it's just, we've looked at these few specific measures and developed some samples for them. On the clinical data exchange side, we've got several profiles there as well, several use cases. So this HREX, the Health Record Exchange Framework and Library, is kind of the foundation, defines some certain, some baseline services, FHIR profiles. There's several of the core FHIR resources are profiled in there. And then building on that foundation, we have the payer data exchange to pull data from payers, clinical data exchange, pull data from providers, but they work in very similar mechanisms, same sort of FHIR resources, similar types of interaction models. So this tells you a little bit more about this clinical data exchange. So you can see the sort of overall flow here, where you can actually have a like a Smart on FHIR app. I don't know how much are people familiar here with the Smart on FHIR, where you can write custom apps and plug those into third-party EHRs in a standard way, right? And it actually acts as a new feature. It's like built into the EHR's user interface, and then can carry out some of these interactions. Of course, everything is secured, working through the standard OAuth 2 mechanisms, which is recommended and typical for FHIR implementations. So Da Vinci's been around for a couple years now. We had our sort of big coming out at HIMSS last year, the big health IT conference and trade show. It happens every year. Was anybody out at HIMSS last time? Show of hands, a few of you. So hopefully you got a chance to stop by the Da Vinci booth in the Interoperability Showcase if you were there. If anybody's coming this year, we're going to be back again in Orlando starting March 9th, I think. So Da Vinci again will have a booth there. And what we do during the demos is we show a complete end-to-end simulated patient journey, where a patient comes in with some medical conditions. She sees her PCP, gets referred to a cardiologist due to chronic obstructive pulmonary disease, COPD, cardiologist, and then gets her admitted to the hospital, stays there for a while, and then is discharged out of the hospital with home oxygen therapy, and then returns to the PCP for follow-up care and does medication reconciliation after that. So all these interactions you see, which, for the patient is moving between different parts of her care journey, seeing different providers, all of that is handled through Da Vinci interactions. And what was really cool in this demo, and I think there's a video online if you want to search it out for like Da Vinci demo HIMSS. I think that's online. But we're able to repeat this demo several times and swap out the participants, so we can have UnitedHealthcare as the insurance company for one run, and then the next run it can be Blue Cross Blue Shield of Alabama, and the next run it can be Humana, right? Because we've all implemented the same Da Vinci implementation guide, is stuck to that standard, and so it all works exactly the same from the provider's perspective. So that was one of the big events. Has anybody been to some of the HL7 Connect AThons? Show of hands, a few people, yeah. So Da Vinci always has a presence at the HL7 Connect AThons. Those happen every few months in line with the HL7 meetings and sometimes out of cycle as well. So we've been at those. We'll be at HIMSS again this year. So if you're coming to HIMSS again in March in Orlando, please stop by the Da Vinci booth. You can watch the live demo, see the real interactions in action. If you'd like to get involved, we are absolutely encouraging more organizations to get involved, whether you're a payer or a provider or a vendor selling to payers or providers. We'd like to have you get involved in Da Vinci. This is an official HL7 FHIR accelerator project, so everything runs under HL7 governance. All the meetings are public. If you do want to actually formally join the project, you do have to pay an organizational membership fee to do that. But all of the work products are freely released and open source, so the implementation guides are posted up on the FHIR website. We also have reference implementations that we've paid contractors. The project has paid contractors to write those reference implementations, so you can download the source code off GitHub and use that as a starting point. We also have documentation online on HL7's wiki on Confluence site, so that's all available as well. So if you're interested in getting involved, again, it's a great project. We'd love to have you. So I'll close with just a few words about what we've done within UnitedHealthcare to implement Da Vinci use cases. And so our delivery vehicle for those, something that we call EAzl, the EMR Integration Service Layer. It's not a product I'm trying to sell or anything. That's just an internal tool that we've built. So the mission of EAzl vision is essentially to act as a gateway at the boundary of UnitedHealthcare systems, talking to provider EHRs, EMRs on one side, and to our internal systems on the other side. Now, those internal systems, UHC has been around for a long time, grew up through acquisitions. Most of those systems don't speak FHIR natively, right? So we have to translate back and forth. But the goal here is to ensure that that all of our network providers have the data that they need at the point of care to deliver high quality care to all of our members, and that we're getting the data in that we need to verify that and to conduct our business operations. Some of the key capabilities of EAzl include, that leverage FHIR include what we call a lab chase service. So, if we're missing a lab result for one of our members, we can actually go out and query the lab's FHIR endpoint and pull back those observations. We can have something that we call managed pull service, where we can reach out to our network providers if they have a FHIR endpoint and pull back the relevant pieces of a patient chart. We have also implemented pieces of the data exchange for quality measures use case, particularly for that medication reconciliation post-discharge. And we've implemented at least pieces of the payer data exchange use case. So we have an endpoint for that. So again, that's EAzl product. It's sort of a proprietary internal product is what we use to centralize development of the Da Vinci use case implementations. So here's kind of a high-level architecture diagram. I don't know if it's very readable, but you can see on the on the left side the clinical sources, which are basically our network providers, the doctor's offices, the hospitals, as well as reference labs and other sources. So we have those sitting on the left, and we can work either using a pull model in some cases where we query to them, or a push model in other cases where they push to us. So we can act both as a FHIR client and as a FHIR server, depending on what's needed. All right, so in closing, just like to thank a few people. Most of the content in the slides came from the Da Vinci project, especially it was created by Jocelyn Keegan, who manages the program overall, and Viet Nguyen, who's the technical lead and a doctor himself. And some of it also came from my colleagues at UnitedHealthcare, including my bosses, Sagran Moodley and Yogesh Rao, my colleague Lucas Nosal, who's our architect. So Just wanted to acknowledge them. All right, so that's it. Any questions?
So you mentioned the dependency on X12, the interaction with X12 because of the laws and some of those exchanges.
Yeah, it's mandated by HIPAA currently.
So have you had tension or pushback because X12 is sort of vague, I kind of have access to the standards. It's just they operate very differently than sort of FHIR's open environment, open documentation. Has there been any tension in that interaction?
Yeah, so I don't know if everybody heard, but the question was about dealing with X12 as a standards organization because they're traditionally more closed and they don't release content freely. They do charge for their standards. Fortunately, they're kind of coming around and opening up and collaborating and cooperating with Da Vinci Project. Some of the folks that sit on HL7's financial management work group are also members of X12, so they've been able to act as kind of a bridge, and there's some high-level context between HL7 board members and X12. So it was didn't get much press, but X12 did actually recently release a free data mapping spreadsheet that goes between FHIR resources and certain X12 claims transactions, specifically in support of this prior authorization Da Vinci use case. Yeah.
There was a number of implementation guides. Just curious what you guys used for profiling FHIR resources.
Yeah, good question. I was not personally involved in the...
I can answer that. We all have our own methods of doing this.
Yeah.
So there's a variety of things. You got
Yeah.
a couple tools like Forge has a tool.
Yeah.
There's Rick Geimer's tool. What is it?
Yeah.
out there. I forget
I know I've
Spreadsheets, I was just
I've seen the demos. They're,
Forge was not easy.
I use Excel spreadsheets.
yeah.
That's the classic one. So did I.
Back there?
Made a comment something on the slide about making it available to UnitedHealth clinical site. So does Optum clinical practices have an advantage compared to other clinical vendors in getting access to UnitedHealthcare claims data?
So the question is whether Optum Care provider organizations have an advantage in getting access to this data. Answer is no, not really. There's kind of at least a soft Chinese wall in the organization. We don't, from our perspective, we don't give any special preference to one provider or another. It's honestly, it comes down more to who wants to work with us and cooperate and collaborate and actively, develop these interfaces. Thanks.